slide in there. I teach for the Academy of Pelvic Health and Obstetrics, some assisting with pelvic health courses, and I also teach on gender affirming care and neuromodulation, which simply stated is TENS or electrical stimulation. And as we go through today, Connie kindly sent me your questions or objectives for the hour, and I really worked to hit all of them. But we're going to talk about some evaluation procedures, some treatment procedures, more specifically focused on the bladder. And pelvic health can include treatments for bowel function. There's some overlap, and then also pain. I did not pull in a lot about the bowel. It wasn't on the objectives that you had, but for questions at the end, I can be mindful to answer some things. So these were the objectives. So we will start with the communication with patients, just some things that we've learned over the years and considerations for trauma-informed care, and really this notion that the patient has the choice about what type of care they get, and our role is to communicate that clearly. We'll talk in some overview about the anatomy, pathology, and limitations of pelvic rehab, like what can be done without in-depth pelvic floor training. I am specifically going to pull out some information on neurological, particularly in stroke, because Connie mentioned that you had an interest on that. And we shared some resources that are available to people in Oregon with Parkinson's disease. That's another lecture that includes a urologist and 2 PTs talking about bowel and bladder function in the context of Parkinson's disease. So you'll see that later. I'm going to draw that connection between low back pain and pelvic floor, where it's not really causation, but that they travel together. So more of a correlation. We'll touch on a little bit pregnancy and postpartum pelvic floor when we talk about stress urinary incontinence, because that's the most common impairment, as well as some pain that's related to healing. I've indicated on some of the slides where things might be appropriate for children. And then I sent Connie, I think it was about a 3-page overview on perioperative pelvic physical therapy in the context of pelvic surgeries. And there's a lot of good evidence for that, but we didn't really have time to go through all that. Then the manual techniques and exercising is getting into the treatment. So we have a lot to cover in this hour. And Connie, I'll try, when I get to like transition slides, I will let you know. So your perioperative PT content was really primarily focused on post-op and pre-op hysterectomy for people, for women, and then prostatectomy for males who are having the prostate removed related to cancer. So you have a lot of information for them. The things that we're going to talk about, you could teach people how to use their pelvic floor, how to exercise well, how to breathe well preoperatively, but I'm just not spending a lot of time going into the evidence on that. So I also kind of made a key as we go through the slide. So if you see this icon, it means appropriate for female or male. If you see this person with a cane, it means it could be appropriate for an elderly population, the pregnant person. So this icon, whether it's appropriate or there's a consideration, the brain is to say, okay, what are the considerations in neurological, pediatric? And then the null sign here will be over the key where the examination or the treatment really is not appropriate for that population. And then the question mark is more, you should think more clearly about it before you proceed down the path. So that's whether it's a map or a key, that's how they'll be used here. And I hope you find that helpful. It's a great way to get a lot of information in a short time. So pelvic health It's exercise training. I love doing that. It's the pelvic muscles and additionally the abdominal muscles. The hip muscles are really important, specifically the posterior lateral hip group, glute medius, gluteus minimus, and the obturator internus. Coordinating breathing, because breath holding can contribute to lots of problems in the pelvic floor. We educate people on position for toileting, particularly in bowel. We can also give people advice on positioning for sex to make sex less painful and other activities in their life. Manual therapy can be part of this, and this would include joints, muscles, and nerves. So maybe some of the things you've learned from the orthopedic spine focused education that you have had, things like sciatic nerve stretches, hip flexion stretches, hip joint mobilization. We also, again, for bowel patients, will do a bowel massage. With technology, we can do EMG biofeedback. So it's an electromyograph that's measuring the activity of the pelvic floor muscles and the ability to isolate. Electrical stimulation, we will talk about the TENS later. It also can be used as a muscle stimulator in the pelvic floor. And then we can touch on basics of nutrition, including fiber, fluid, and some common irritants to the bladder. I've given lectures similar to this to physician providers and then other PT colleagues. Sometimes patients are afraid to come to pelvic PT because they've heard it's going to be painful, or they've heard that it has to include an examination of the vagina, or it has to include an examination anorectally. And it doesn't have to. Patients have choice. We'll talk about it as a PT in this practice. Really, I really want you to know that we're going to have an hour here today, but there's a lot that you already know that can help your patients who have pelvic health conditions. And as you talk about what the options are, just be mindful to consider that. So we always, if there is any type of internal pelvic work, or really any observation of the perineum unclothed, or any palpating in the perineum through clothing, it's always with consent. And I have some examination considerations coming up. And we never say to the patient, the best way to do this is with an internal exam. I'm going to get the best information with an internal exam. That language can be considered coercive. So the patient gets to choose, and they get to choose when it starts and when it stops. So you can do your range of motion and strength testings of the back, abdomen, legs. You can look at the perineal area, touch the perineal and pelvic floor area with permission. The EMG, I'll have a small image coming up where the sensors will go. They're very small sensors that go near the anal opening, and they're representing the electrical activity of the whole pelvic floor. For most people, the most familiar similarity would be an EKG, where that is an electrocardiogram. And then for adult patients, we offer the internal vaginal or rectal exam. So when taking your history, you're going to want to consider not just what's going on with their bladder and bowel and the pain in the abdominal area. How easily do they get to and from the bathroom? Sometimes urinary incontinence is because the time that the signal is sent, it isn't enough time with a person to walk with their walker unbutton their pants, lift the toilet seat, or transfer from the wheelchair. So sometimes even with all the skills I have, the best piece of information I might give someone is to wear clothes that don't have buttons so it doesn't take you as long to remove the clothing. When, again, in the evaluation, we're going to talk about diet and activity level. So generally, we're looking at a range of 5 to 9 servings of fruits and vegetables combined in a day for an adult, and that's about 35 grams of fiber. We want 50 to 80 ounces. That would be around approximately 2 liters of non-irritating fluids. And then we want to ask about their hobbies and recreation. What types of activities do they do? And what's the timing of those activities? So as people get old, they tend to move less. They also tend to rotate in their trunk less. They're not using their hip muscles as well. And so those things, maybe their activity level has reduced, or what they loved to do, they can't do anymore. So you're going to be looking for ways to restore that. Sometimes if the patient is there alone, not with a family member or caregiver, sometimes getting some of this information is difficult. And so I might just move forward from that and write down some suggestions. Maybe there's a loss of taste, maybe there's a difficulty chewing. So just considering all the other aspects of PT that you've already learned. This is now specifically talking about children. So if we assume that a certain percentage of fluid is coming from drinks, because fruits and vegetables are very high in water content. So I hope our pediatric people have joined us. So in the 4 to 8-year-old range, you're looking at about 1 to 1 1/3 liters per day, and that's about 33 to 43 ounces. In the 9 to 13-year-old range, you're about at 1.5 liters per day, or 33 to 60 ounces. And boys tend to be on the higher end of that. And the source for this is the European Food Safety Authority. For fruits and vegetables, you have this image here, and you can get it from the US Centers for Disease Control, that we're looking at, about 2 cups in the age 2 to 3, 3.5. And then when they're kind of entering their teen years, they're up to really almost an adult range of fruits and vegetables. When talking about lifestyle, caffeine is a big irritant. It's the heavy hitter. Sometimes acidic drinks, things like citrus and tomatoes, can also be irritating to the bladder and increase urgency and a discomfort with voiding. But really, when I'm talking to people, if I'm suggesting that they eliminate or reduce anything, it is the caffeine beverages, then carbonations, then maybe the fruit drinks. Artificial sweeteners, so this could be in beverages or in things like gums and mints. So some artificial sweeteners, things like sorbitol and xylitol, the sweeteners that end with that OL letter, they are alcohol sugars. They make food taste sweet. They also tend to increase the activity in someone's gut and can lead to discomfort and bloating and potentially diarrhea. So just a little touch on bowel there. I don't know about where you are in Asia. In the US, there is a lot of discussion about gluten and gluten allergies and sensitivity to wheat. sensitivity to dairy, and then sensitivity to sugar. I will talk about those some, but I'm also want people to have a well-balanced diet, and it can be challenging to try and eliminate too many foods from their diet. For output, and so one way to, sometimes people will have a difficult time answering how much they take in, and they're not often measuring how much leaves, but it can be a question, a way that you approach the question. Generally, adults urinate about 1 ounce per second. So if people count slowly, 1, 1,000, 2, 1,000, 3, 1,000, while they're urinating, you can get a sense of what the volume of the urination is. And generally, a normal volume is anywhere between 8 and 16 ounces. In a day, someone should urinate 6 cups. I don't often have people measure that, although there are toilet hats, like plastic things that go in the toilet to measure it. I do often ask people about the color of their urine. So ideally the urine is pale yellow, and I have some color images coming up. It doesn't need to be clear, but you also don't want it to be too much toward orange. It is normal to urinate between 5 to 8 times while you're awake. So that 16 hours that people are awake. And for people under the age of 65, waking not at all is great, or waking 1 time is acceptable. Over the age of 65, because of some changes in the way the hormones that affect the kidneys alter, older people may wake up to twice a night to pee. If it's over 2 times a night, and I have some solutions for nocturia coming up, that's what that is called. We can think of this just as a bladder problem, and oh, you shouldn't be waking that often. But in your neuro population or in your elderly population, we also want to consider the fall risk of waking up that many times at night, tired, dark, maybe a little bit disoriented. So here's a place where improving bladder function can really improve safety for someone. And you can Google this information, where you can get images of the colors of urine, where the hairs are pale yellow color. I have in my office, this picture doesn't truly represent it. I just took some Post-it notes, so little Post-its like this, and I have a pale yellow one and a dark yellow one, and I just have people tell me which Post-it note represents their urine color. So for a kiddo, let's just really talk more. So for somebody who weighs about 50 pounds, their daily urination volume would be about 2.5 cups. For somebody at 75 pounds, about 4 cups. And for someone who weighs 100 pounds, about 5 cups. And it would still be that same frequency of about 5 to 8 times a day. Many of the children that I see with urinary urgency and leakage related to that, a lot of it revolves around them deferring for too long and really postponing it for too long. So when talking about urinary leakage, and we're just going to talk about the 2 basic kinds of urinary leakage. So this acronym stands for urge urinary incontinence, and this is stress urinary incontinence. Urge urinary incontinence is often described as a problem of the bladder, that the bladder is too active. And I have an animation that will happen here, fingers crossed. And so the bladder is just spasming empty me, empty me, empty me. And the person's nervous system can't distract themselves from it. And sometimes the bladder wins and urine comes out the urethra because of that spasming. I think I can make it go again. Yep, there we go. And stress urinary incontinence is generally described as a weakness of the pelvic floor. So the pelvic floor muscles don't close sufficiently the pressure in the urethra. And a cough or a sneeze, which will result in a downward pressure onto the bladder, then results in leakage. And this could happen with coughing, sneezing, laughing, or sometimes heavy lifting. So again, urge urinary incontinence, often described as a problem of the bladder. I tend to think of it as a problem of the nervous system, and that will come up a little bit later. And then stress urinary incontinence as a problem of the muscles. When talking about bowels, normal bowel function, people could have a bowel movement 3 times a day. That's great. It's not too much. People could have a bowel movement 3 times a week. That's great. It's not too little. Most people really want to have 1 a day, but they're still inside that normal range if it's either of these values. People should never have leakage of stool. That's what fecal incontinence is. And then this is a Bristol stool chart. And the ideal stool is this type 4 stool. There's many versions of the Bristol stool chart in multiple languages. I think you might be able to find it for your own language. So 4 is ideal. 3 and 5 are kind of acceptable poops. Maybe the person's a little bit dehydrated. For type 5, maybe it's that artificial sweetener. But when people are getting into 2s and 1s, they're not getting enough fiber or enough fluid or enough activity that stimulates bowel function. And then type 6 and 7 are considered a type of inflammation or irritation in the bowel. Pain. So when evaluating for pain, similar to your other pain conditions, when did the pain begin? Where is the pain located and what provokes the pain? And then what eases the pain and what treatments have been effective? With provoking activities and you're thinking about the bowel or bladder or something of the digestive system, you want to be sure to ask questions. If the person says, I don't know, it just seems random, then you can ask questions about, well, does it happen an hour after you eat? Does it happen 3 hours after you eat? Is it right before a bowel movement? Do you feel better after a bowel movement? Do you have pain with urination? Do you have pain prior to urination? So you're looking to link it to something in the urinary or bowel system. We talked a little bit about asking questions about bowel and bladder. Sometimes bladder or bowel diaries can be helpful. And I'm not going to go through every aspect of each of these. But when a person, like a professional like you, first learns about bladder diaries, they're really complicated for the patient. You should try filling this out for yourself if you are going to ask your patient to do it. So every hour, they are asked to record what they're drinking and the amount. And then, did they go to the bathroom? What was the volume? Did they have a leak? What was the volume? Was it associated with urge? Or were you like running, jumping, sneezing? So for 24 hours, and each hour, they're answering all of those questions. And when I first started doing this, I would ask patients to fill out bladder diaries, 3-day bladder diary. And the issue is if you miss just a couple data points here, all of the data becomes bad. Like it's not enough to track progress. So over time, I have, through more education, simplified it. And this was first for children, like, well, what happens in the morning? Like, are you generally dry? Do you go to the bathroom right away? What happens at breakfast? Do you eat and then poop, or do you skip breakfast? And so this can be a little bit more simple for people. And instead of a page only worth one day, this gets to be worth 1 week, just 1 week. So then sometimes people, they just wanted one page to track a longer volume. So since we talked about how people can have day and nighttime symptoms, this was a different progression of a bladder diary, which was like, okay, what happened on Monday during the day? Did you have a leak? How many times did you pee? Did you have a bowel movement? Were there any stains with bowel movement? What type stool did you have? But where you could see 1 month on one page. And more, I use something that I call a personal bowel and bladder diary, where when I try to get the information just through questions and answers. And if people have a challenging time answering the questions, we talk about a diary and I let them choose, or I ask them to choose, what are the things that matter to you? Is it really like, is waking at night what bothers you? Or is having accidents during the day what bothers you? And is it the bowel symptom that bothers you or the bladder symptom that bothers you? So they're deciding what to measure, and usually doing it on just it happened, it didn't happen. I often include a Bristol stool chart. I had a patient recently, she chose 4 different categories, like, was it painful? How easily could she wipe? And she couldn't use my scale. So she did, I don't know how your grading system is, but in America, our grading system is A, B, C, D, F. So she gave each day a grade on those different variables, which wasn't a way that I ever thought about it. But we were really able to look at, well, this week you had mostly C's and maybe 1 B, and this week you had mostly A's and a B, and it really became a way to track progress for a person who was having difficulty kind of quantifying what was going on with her. So let the patient be the guide to a certain extent. When we're talking about the examination, you can look at it externally, so you can assess the tone with your touch. You can't really assess the strength, but you can assess the ability of the muscle to relax and contract. And you can do palpation or EMG biofeedback. For some children, they don't want to expose their bottom. The elderly, sometimes they might not understand why it is you want to do this. For people who have stroke or Parkinson's disease, that could be difficult. And I will say it doesn't always give me information that changes it. In a pregnant person, it's usually safe. Talking about internal exam, in a female, it usually will be vaginal, and then males will be anal. I also work a lot with a transgender population, and this is a transgender vaginoplasty. So that would be the internal exam. For internal exam, I don't do any internal exams with children. And in the first trimester or in a complicated pregnancy, you would not do an internal exam. And then just because of cognitive function, really being mindful of an internal exam in the elderly and people with neurologic changes. So if you can't do the internal exam and you can't look at it, assessing the hip muscles, so gluteus medius, gluteus minimus, and the obturator internus, those weakness in these muscle groups have been associated with low back pain in non-pregnant people, with low back pain in pregnant people, with urinary stress incontinence, urge incontinence, and pelvic floor pain. So you have something you can assess and change. The obturator internus is the primary hip external rotator we're talking about. And that is because it is the attachment point of the pelvic floor muscles. And if it is not functioning well, the pelvic floor muscles cannot function well. And this rotating image, the obturator internus, starts on the inside of the pelvis and attaches to the greater trochanter. So now we're going to get into treatment. Connie, should I pause?
There's no question, so
Okay.
go ahead.
Okay. So we're going to talk about stress urinary incontinence, nocturia, urge-related incontinence, and pain. And the way I've kind of formulated this, almost any treatment you would do for stress urinary incontinence is going to help someone who has nocturia, is going to help somebody who has urge-related symptoms, and then will help someone with pain. So we just told you what good fluid and fiber intake was. If they're not meeting that goal, you're going to encourage them to get there. So your evaluation flows really nicely into treatment. We talked about things to avoid, like things that you want to ask, are they consuming these? And I can think of patients who I didn't really talk that much about artificial sweeteners. And then 4 visits in, they said, oh, I was chewing a lot of sugar-free Bubblicious gum and I stopped doing that and my bowels are great. I'm like, okay, I need to start asking that. If people are going to give up these beverages, Kava and Ovaltine are, US-based things that they can drink. Water is great. And then things like cranberry juice, apple juice, grape juice, but non-citrus beverages. For stress urinary incontinence, and remember I said that was primarily a strength issue. So they're considered to be underactive muscles. There are lots of studies on and opinions on how to strengthen them. This Garcia Sanchez article looked at it was a systematic review and it looked at studies who actually looked at something called a pad test. Did these people leak when they coughed? Did they leak onto a pad? And the exercise programs that seemed to show benefit, if people were doing slow contractions, which meant holding for 5, 6, or 10 seconds, was helpful. And a combination of rapid, so what we call quick flicks, so something that is just on and off and on and off. Something to catch the cough leak. People need a rest time between contractions in all scenarios. So generally the rest time is either equal to or double the work time. You want to make sure that they can completely relax, especially in a pain condition. And then they talked about 9 repetitions per session, so at a minimum, and doing like 3 sets, and that they should recover between sets. So very similar to a strength and conditioning program where you do a set of about 10 reps, you rest, and then you do another set. And that you should see results within 6 weeks if people are being diligent with that. And if oftentimes we start with people lying on their back or maybe on their side, so varying positions, so moving that to sitting and standing can be helpful. Using biofeedback or vaginal cones, which are vaginal weights. You can, if they have to do more fast contractions, that's going to build power a little bit better, or if you increase the hold of it. I oftentimes, and we'll have another animation here, to help people facilitate the best Kegel contraction, I'll have them exhale, making a sh or an SH sound. It is the most restricted exhalation of air sound. And so the pelvic floor muscles and the abdominal muscles have to work to push the air out. So you're going to see this go up. Oh, wait, there it goes up. All right. And then there have been a couple of research studies looking at if people do things like a plantar flexion maneuver, so push their toes into the floor, that can suppress the bladder. And also when people do something like a toe stand in this upright position, that will contract their pelvic floor. If they do a heel stand in the upright position, that contracts the pelvic floor. With concerns for balance, I will sometimes just have my patients do toe curls. The thought process here is that the nerves that leave the sacrum innervate the pelvic floor muscles in that region, and they also continue down the leg to innervate all of the muscles of the lower calf. And it also challenges balance, which is puts a good demand on core muscles. So here are just some illustrations of a heel raise, toe taps, ankle bends, and then that ankle rotation, just to facilitate more in the pelvic floor. I showed you how it was related to the sacral nerves. This is an image of the homunculus, and on the motor homunculus and the sensory homunculus, the foot and the genitals are represented in a very close proximity to each other. When thinking about hip strengthening, your exercises don't need to be complicated. A simple bridge will activate the obturator internus and the gluteus medius and minimus, as will a plank. This is a specific standing hip abduction exercise. She's gonna move her leg there. Oh, no, we missed it. So those are some ways to work on hip strengthening. And when someone's lifting their left leg, the right leg is working to stabilize. Okay, now we're going to move to nocturia, which is waking too often at night to urinate. So some basic advice is to avoid fluids after 6 p.m. or about 2 to 3 hours before bedtime. Also, elevating the legs before bedtime to get the fluid that's accumulated in the lower extremities back into the general circulation. Sometimes people are waking to urinate because they have sleep apnea or other problems with sleep. Maybe they have cardiovascular disease or it's medications that they're taking. So you may need to involve your medical doctor team. And these are particularly things I address a lot with my patients who are elderly or have some type of neurological disorder. Bed mobility exercises, they're not complicated. It's more about timing. And the idea is that you pump the fluid back into the general circulation. So urine can be processed by the kidney, enter the bladder, and they can empty their bladder before going to bed so they wake less. It's also great for range of motion and can help with bed mobility skills. The exercises are really simple. We're not concerned about a certain number of reps and sets. It's just to move that fluid through the system. And again, for the elderly or somebody who has a neuro impairment. Urinary urge incontinence, remember I told you, I think it's nervous system related. Some of the treatments are really looking at behavioral, those fluid and timing of fluid. And then transcutaneous tibial nerve stimulation is a great treatment for that. So some of the behavioral stuff, make sure when they're sitting that they do empty their bladder. Commonly, people have leakage when they're arriving home. So sometimes I have them practice, well, urinate, then leave and come back. So you're breaking the association of when I arrive home, I always use the bathroom. And then a bladder schedule can be something that they never get in that, oh, I waited too long to empty my bladder. And to suppress the bladder, maybe you're thinking this slide looks familiar, and it does, Because activating those same muscles in the feet can be really helpful to calm that bladder spasm done. There was one small study, but a very well done study that looked at this. And not only did the person's perception of, oh, I need to urinate change, it also changed that the spasms in the bladder. Neuromodulation, so that's going to be the TENS. It's helpful for overactive bladder, urge incontinence, also fecal incontinence, constipation, pelvic pain. You would not use it in pregnant women. You would consider using it in someone with a neurological impairment, but you'd really want to make sure they understood what was happening. And generally, you would not use it in somebody who has a pacemaker, although oftentimes the cardiologist will give permission for it. But otherwise, I use it with men, women, the elderly, and I also use it a lot on children. So just pulling out some information specifics to stroke, where they looked at, I think it was a total of 3 studies, 80 people, and giving people pelvic floor muscle training did not help their urinary function compared to people who didn't get pelvic floor muscle training. But in another pooled analysis that was 224 people, the electrical stimulation treatment, so the neuromodulation, did have a significant effect on the urge urinary incontinence symptoms. So in your stroke patients, the treatment I'm about to talk about could be effective. So generally in those studies, I don't know how much you know about electrotherapy. The hertz range was either 20 hertz to 75 hertz, most commonly 20. The pulse width, so the pulse duration, was 70 to 250 microseconds. The duration of treatment was 20 to 30 minutes, and they did it for about 5 to 7 times a week. We often have people get a home unit for that. So you are placing the electrodes on the tibial nerve where it is very close to the surface, because the current can jump right on the nerve and travel quickly up. And we know that it is incredibly effective, and it is to be determined if that is happening at the sacral plexus, at the bladder, or higher up in the nervous system at the brain. Generally in studies, not those stroke studies, but just in studies of neuromodulation, the frequency tends to be in this low range between 5 and 20, the pulse width in a 200 to 400 microsecond range. And when people turn up the intensity, you want it to be strong, but not painful, and no contraction. And then they'll increase it throughout the session. And it's been studied doing it for 30 minutes, 1 to 3 times a week. Here is that common placement on the tibial nerve. If people have neuropathies in their feet, I will sometimes put it on the abdomen, suprapubic area. It also can be placed a little lower than what's illustrated here, but near the C3 nerve. In talking about pain, so this is just an image of allodynia, so pain with a type of stimulation that shouldn't be painful, and hyperalgesia is too much pain. When we're thinking about the pelvic floor, we can palpate externally or internally if the patient has permitted that. Oftentimes people go to manual therapy for this, thinking about trigger points and stretching and internal stretching of the area. Manual therapy for the pelvic floor could include lumbar and hip joint mobilizations as well. If you are someone who is going to do internal work, it shouldn't be painful to try and relieve the pain in that area. A lot of the studies, people had 8 to 10 sessions that only lasted 5 minutes, and it's only one part of the PT program for pain. And I'm on a soapbox here. Kegels and exercises can be really good to reduce pain. If the pain is vaginal, we'll talk about vaginal dilators, EMG, and I already mentioned that E-stim can be helpful for pain. So it's only part of the program. So a study that gets cited often, and this was looking at manual PT treatment compared to just general massage. And the people that got all of this treatment got better than the people that got this treatment. And in my, it, to me, it's volume based, and this treatment was very specific. It included the option for the patient of having internal work, but even then it was not painful. It included pelvic floor contractions, just not a lot of them, and it wasn't the first thing. And oftentimes, this is the study that is cited to say, like, manual work is better for pelvic floor, and there was just too much going on here. This study is also oftentimes cited as the reason that people should not do pelvic floor exercises if they have pain. But that was the opinion of the author. It has not been cited in research that contracting the muscle is going to make the pain worse. And I just think that's such an important concept. I'm a big proponent of exercise, and exercise can change many symptoms. Sometimes simple stretches. So this, like a child's pose stretch, where you're really stretching the posterior lateral hip. People can do deep breathing here and really help to stretch the pelvic floor. And back to, again, you've seen this slide before, doing strengthening exercises for, thank you. Doing strengthening exercises for the obturator internus, glute minimus, glute medius. So a lot of hip abduction work. So we're talking right here. I don't know if you really wanted to give me that because I'm having too much fun with it. Getting these muscles stronger can help a lot of the pelvic floor symptoms. Okay, can I get by now? Okay, now I can't move forward. So Connie, we should pause for questions while I figure this out.
Okay. Does anybody, excuse me, does anybody have questions to come unmute?
My red line stayed.
Any physical therapists have any question for our speaker?
Okay, I'll go on.
Anyone have anything in, I don't see anything in the chat box, and don't be shy, please verbally ask. We still have some time.
So these are vaginal trainers or dilators. They can be helpful to desensitize the vagina after radiation or after childbirth. They also stretch the vagina. They also should not be painful. Like the manual therapy, they should not be painful. When it's painful, people tend to tense the muscles and it begets more pain. Here is an illustration of where the sensors are placed. This is male pelvic floor anatomy, where there are two leads placed on that perianal area. They provide a graphic representation, and then a second channel on the gluteal muscles, and here on a female pelvic floor. It should be a coached experience where the therapist is watching what's happening and helping the patient relate what they're seeing visually to what they're feeling inside of themselves, so they know how to relax the pelvic floor, commonly used with pain. So when you're thinking about pelvic conditions, and you're thinking about treatment, really education and self-care is going to get a long way with the patient. So things like diet, exercise, the types of fluid, the timing of activity, including those bed mobility exercises. Movement can be really helpful. So the bridge and lower trunk rotation, a plank, and child's pose, things that activate those hip and abdominal and pelvic floor muscles, and then things that stretch them for either condition. Things that can be done with the hip and foot to help suppress urgency in the short term, and then also facilitate more coordination in the pelvic floor in the long term. Electrotherapy, as much as I love it and do it early for how I see my patients and their access to care, for me, it becomes part of the home program, but it can have a lot of value with urinary urgency and fecal urgency. And interferential current is another type of stimulation that can be done for bowel function. Bowel massage can be helpful, and manual therapy, I don't spend a lot of time on that in the clinic. It's really a lot of self-care. And then the EMG biofeedback, I love being able to teach people with the EMG biofeedback, but I don't do it for 12 visits. It's really just that 1 to 3 range. I told you already I was an advocate for exercise, and so I'm just going to end there. Oh, I saw a question.
There's 2.
Oh, and here, Connie, like we provided this info. This is the Parkinson's disease lecture that Allie and I did, and another urologist. I am going to, there's 2 questions. Okay.
Do pelvic fracture and recent UTI affect the pelvic floor muscles?
So I'm going to answer it as 2 separate things. So the symptoms of UTI and the symptoms of a overly contracting pelvic floor can look similar. And so the UTI should be diagnosed with a urine test that's sent off to see if bacterial grows. Because when people urinate, if they have a UTI and they're urinating, it's usually painful to the lining of the urethra. And so sometimes people will tense the pelvic floor because they want to urinate, they have to urinate, but the body also doesn't want them to urinate. So it can be a contributor to the pain. If somebody has had frequent UTIs and they've learned that pattern of not really liking to urinate, then the muscles can, for lack of better phrasing, get stuck there. And that would be a place where those relaxation exercises like the child's pose or deep breathing, maybe some massage could help them relax. A
Okay.
pelvic fracture, it would be hard to discern, is the pain because of the pelvic fracture, or is the pain because the pelvic floor is spasming because it's trying to create stability in the pelvis. So the doing pelvic floor exercises in the context of a pelvic fracture is very unlikely to displace that fracture. Their line of pull isn't going to be enough. And they're still going to urinate and defecate. So there are going to be changes in that pelvic floor.
Okay. Bowel massage. Must it be done by PT only, or can patient be taught?
Oh, I totally teach the patient, and it was one of the slides that I hid. So, and I'm like, can I access it? So, I always teach the patient how to do it. And if the patient is a child, I teach the parent or a caregiver how to do it. And I am going to see what I can do from a slide perspective, or I can send that to you. I think I can. So now you're, oh, you can see this, right, Connie? Am I still sharing?
No.
Okay. I'm going to unhide. I'm going to unhide this slide.
May I ask some question?
Sure.
Of course,
And
Dr. Prabhat.
yes. How about to take care of the patient urinary incontinence in the patient with hydrocephalus, normal pressure hydrocephalus?
So in that situation, so I say this when there are so with hydrocephalus, I envision a child and probably some neurologic impairments. So I would ask all of those same questions about fluid intake and timing, and I would want to know about their mobility and the ease with which they can get to the toilet and the ease with which they can undress, and work on those things before my view was, oh, something in the brain related to the hydrocephalus means this person will always be incontinent. Did that answer your question?
Because I thank you for your special lecture. I think it's more practical for the neurologic patient. In general, we consider the incontinence just only in the pelvic floor part, but your give our knowledge to practical as the holistic like that.
Thank you.
Yeah.
I did. Yes, I think it's so important.
That's one of our most amazing physiatrists
Oh,
talking.
okay. Okay. Yeah, it's really like, and sometimes in pelvic floor therapy, we say things like everybody has a pelvic floor. Like there's always going to be some function. So I think this slide will animate. You can see it, the bowel.
Oh, we cannot see anything yet.
Okay.
Share again.
Okay. Oh, are you still there?
Yep.
Okay, let me get to the right. I see all these icons. Don't know how to switch Wendy's screen. Sorry about that.
No, you could send it to me though.
Okay.
And
Oh,
I
it's just
could.
lovely the way it animates, though. I totally want to share it.
Oh.
Okay.
Well, let me ask you a few more questions.
Okay, go for it.
When is the best time to start pelvic floor exercises after natural childbirth?
Immediately. People can, so if someone has an injury in their knee, we have them do quad sets to help reduce the swelling. If somebody sprains their ankle, we might have them do toe curls or really light activation. We'll have them move the ankle within the safe range. And so if you think of pelvic floor exercises like the quad set of the pelvic floor, that they can help reduce swelling, they can help reduce pain, it can help improve angiogenesis, so the vascularity in the area, which is going to help with healing. It might mean that maybe they're doing it only for 5 seconds instead of 10 seconds, or their actual ability to close tightly around something isn't going to be as powerful, but that movement is really helpful.
Okay, can PFMT help erectile ejaculation problem?
It can, yes. there aren't as many studies on that as there are on things like urinary incontinence. And so generally when you're thinking like urinary incontinence, for the most part, it's a physical, maybe neurologic issue. Occasionally there might be an emotional component to it with stress. One of the considerations with erectile dysfunction is that there are so many influences over someone's sexual function. How do they feel about their partner? How do they feel about their body? What is going on with their general health, their cardiac health? That it's not just, oh, if I can get these muscles stronger, then my erection will be better. It's so much more multifactorial, but it should be considered as part of a treatment for that. But I would say never, and I don't say never often, as the only thing that's going to help.
Okay, which model or kind of biofeedback do you use for teaching patients doing pelvic floor exercise?
So what, can I name a brand, Connie?
Yes, you can.
Okay. Sorry.
Because I bought it. Did I buy it?
So, what I like, so I like the unit we have. It's a Prometheus CTS 1500. But what I like about it is the patient can watch what's happening on a video screen, and I can pause the EMG session and look at what happened just 30 seconds ago and explain to them, on this repetition here, you contracted your buttocks and your pelvic floor at the same time. But on the one before, you were able to keep your buttocks relaxed. And I would like to see you repeat that, because that isolation of the contraction is going to help you control your continence, or it's going to help you reduce your pain. It also, I can change the images. So instead of just a bar graph, it's a circle that gets smaller and larger with the contraction and the relaxation. And for children, it has things like a dolphin jumping out of the water and a spaceship landing and a flower closing and a high jumper jumping, with different sounds that go along with them doing it correctly. So I like that variety. Some of the handheld units just have dots that go up that you can't, you only know what is happening when it's happening, versus being able to look at it in close proximity to it. And Prometheus is just what we've used for a while. There are other makers of biofeedback that are also a screen-based version.
How about yoga effect to urinary incontinence? Because of the many positions of exercise that you show are yoga positions.
Yoga can be really great. So for relieving gas, I like to have people do downward dog or a double knee to chest or child's pose. For stretching the pelvic floor, I like child's pose. For balance, so for activating those hip abductors, you saw the plank and the bridge. Tree pose or mountain pose can be beneficial. The toe stand can be beneficial. So yoga can go a long way. And for people who don't exercise, adding those pieces in can be really helpful. I will say I have some patients who do a lot of yoga and still have problems. And so then you have to go into your PT brain and say, well, are they doing a tree stand but really leaning and not activating the muscles that I want? Or are they doing a bridge with their legs really wide apart, so they're not activating the muscles? So yeah, there's a lot of value in that.
And
Okay.
then
Thank you. Thank you.